Thank you, and thanks for inviting me to Twist, and thanks for joining us today. Great to see you all, and great to see a few people I haven't seen in a long time. All right, I think the introduction gave it away a little bit. I'm not a basic scientist, I'm a clinical scientist, and really my job is to has a lot to do with taking work out of the basic research fields and making it applicable and usable in a clinical scenario and really bringing it directly to patients. So I was very interested to hear what Richard and John had to say today, and already thinking about how we can integrate that into our clinical testing going forward. Let's see if we can get this to work. Here we go. My main employment is through the Victorian Clinical Genetics Service in Melbourne in Australia. So we are a wholly owned not-for-profit subsidiary of the Murdoch Children's Research Institute and are located at the Royal Children's Hospital in Melbourne, which for us is a great location because it really allows us to do what ultimately is our mission, and that is to be the translation partner for the MCRI. We are a very multidisciplinary team with clinicians and genetic counselors, bioinformaticians, clinical and basic scientists, like myself, all integrated within VCGS. And my core focus, at least, is around, as I said, around translation, and is specifically the advent and emergence and ever-growing presence of genomics in all areas of diagnostic testing. We really span the whole gamut of genetic constitutional diagnostics testing. I'll leave the cancer work to Richard and to Peter Mack. But yeah, really from reproductive carrier screening and risk screening, newborn screening, pediatric testing, exome, genomic sequence, biochemical genetics, it's all part of what we do. But again, my key interest is in genomics and how the transition and the revolution that has been brought about by the advent of next generation sequencing has really enabled a whole new era in diagnostic testing. And how can we use these vast amounts of data to get ever more information out of is really one of the core principles that we try to adhere to. It's that continuous integration, that continuous feedback loop between clinical application and research. It's that interface that we operate in, and yeah, actually it's a really good spot to be, especially right now, because there's a lot of work going on both sides, and there's a lot of opportunity to not only get very good academic publications out, but also bring that work directly to the patients and have immediate impact with what we do. Foundational to that is really the shift into comprehensive genomic profiling. We've heard before a little bit about the panel approach, and I think in the cancer field and in the methylation field there is certainly a strong argument for going more targeted, because you've got to go a lot deeper in the vast majority of cases. But in the germline setting, exome sequencing and the advent of whole genome sequencing is, in my view, really where the future lies, because it allows us to really not just solve, in many cases, a problem that's at hand, but also then reuse the data for future purposes, whether that is reanalyzing it and looking at additional needs of the patient in the future, or reflecting that information back into research. So really, exome sequencing is still our workhorse. It is the cheapest, in many cases fastest and most comprehensive testing approach, especially compared to single gene testing and panel-based testing. But it's also still somewhat more cost effective, certainly better value for money, at least at this stage, than genome sequencing. So at VCGS, we've decided to discontinue targeted panels in 2018. And we shifted our whole portfolio to exome sequencing and genome sequencing, really because we have shown that at the scale that we operate, which is actually not that large, Australia is not that big, and there's many other labs that do the same work, so we're not achieving the same scale as some of the big US providers, but even at our scale, at the range of thousands of tests a year, it turns out that this is actually ultimately the best approach. It has shown, and I'll go through some of the data in a minute, to have higher diagnostic yield, even in first pass analysis, and especially now that we're using a twist exome that we've specifically worked with Twist to optimize for clinical application. That has really borne fruit. But as I indicated, it's also got high utility in reanalysis, and again, it overall actually turns out cheaper per diagnosis, but also cheaper on the overall approach, because there's a lot of efficiencies by only running one test instead of running a dozen different panels. Really, a core driver for us was this new targeted panel design that we managed to achieve. This really substantially helped us to solve two key issues. Number one was that exome sequencing does miss known intronic pathogenic variation. That's often a criticism leveled at this space. So we took an approach where we specifically designed all known pathogenic variants in ClinVar into the assay and made sure that, again, we optimized diagnostic performance by specifically targeting and focusing on clinically relevant regions, while absolutely still doing a whole exome approach. So this is not a focused clinical panel. But we have also been able to show that due to the uniformity of the twist approach, we can achieve a equivalent performance in terms of accuracy, sensitivity, and specificity with the twist panels, even at lower coverage. So we're actually now routinely sequencing not at 100x anymore, but at 80x, and we, in the reproductive space in particular, we have shown that we can pull the coverage down to as low as 50x, primarily to save cost in areas where super high accuracy is not quite as essential. Again, generally, the exome space, and this is quite well known already, exomes are known to perform better in the rare disease space. There's plenty of publications out there that they improve the diagnostic yield, simply because phenotyping isn't necessarily always a strong predictor of the genes you should analyze in a rare disease setting. And in the past, in particular, many diagnoses were made outside the routine or the standard targeted panels. But also, and that's probably the much more pertinent point, we are far from having discovered all disease genes. And even for the genes we know, we don't necessarily know the full phenotypic spectra. So there's a constant expansion, and panels and gene panels, and while we're still using in-silico gene panels to guide our analysis as a measure of efficiency, because it's still a useful approach, we would always go to all known disease-associated genes on negative cases, and at times beyond that, because the panels aren't stable, in and of themselves are not stable. The body of knowledge constantly changes, and we've done a little analysis at the start of last year, and we've shown that over 50% of the in-silico panels that we have, so that's about 120 different disease indications for in-silico panels, over 50% of them had changes in a 12-month period. Some of them had as many as 150 or more genes changed in them, so that's far from stable. On top of that, literature clearly shows that negative cases benefit from reanalysis. Estimates range between 5 and, I mean, it says sometimes 80%, that's maybe a bit high, but in reality, probably between 5 and 20% of cases have, if they're negative cases, if they're reanalyzed a year or two down the track, actually obtain a diagnosis. And the literature also shows that the vast majority of these new diagnoses are actually stemming from new gene disease discoveries that were made in the interim since the case was first analyzed. If we actually look at the rate of gene discovery in 2022, that's perhaps not that surprising anymore. So last year alone, we've added over 350 genes to our Mendelium. This is done through work in collaboration with Panelab Australia. Many of you may be familiar with Panelab Genomics England. We've got an Australian version that was started by my colleague Zonitza Stark in Australian Genomics probably about 2 or 3 years ago now, and we are steadily and routinely updating that every month. And you can see that over half of these genes that we've added are what's called green genes. That means they have immediately enough information and evidence to be counted as clinically valid gene disease informations, whereas amber and red genes have a lower threshold, they need a little bit more information, but over time generally make it across that threshold. I just want to put in a little bit of an extra plug for Panelab Australia. It's an open sourced and free tool that everybody can use and contribute to. So if you got your favorite disease genes you want to add, please describe it here so we can really increase the body of knowledge, and all our panels, as well as some of the panels of our collaborators, are available on Panelab Australia. Very highly recommended that if you're in the rare disease space, have a look at that resource. It's very, very useful. And we have used that extensively to work with some of our major initiatives in collaboration. So McKinsey's mission, for example, a big carrier screening, expanded carrier screening cohort is on there, and other projects that we're now starting will also have their gene list published on Panelab and be immediately publicly available. Now, why does all of that matter? Because it really ultimately helps our diagnostic yield. What we can see here is that even in the first pass analysis, our full Mendelium analysis, so Mendelium is what we call our largest in silico panel that has all the known disease genes, which now approaches over 5,000 genes. On there, we get a 45% diagnostic yield across all indications, so that's our average. Whereas if you compare that to diagnoses that are made on targeted or more focused gene lists, we actually only get 28%. So we do offer tiered in silico testing approaches, even though they're backed by exome sequencing, where people can choose only to focus on a subset of genes, but the diagnostic yield is markedly lower. What this graph also shows is that, and I might use a mouse, because that way people online should be able to see that, is that when we reanalyze cases, after we get a request for reanalysis, 19% of these cases then achieve a diagnosis, and again, most of that comes from new disease genes. But this graph also shows that the rate of reanalysis currently is desperately low. So there's clearly a lot of patients in our negative cases that we're currently missing, and that's something I'll get back to later. Really, exome sequencing is, as I said, now the backbone of what we do. We deploy it across a whole range of areas. Diagnostic is the obvious one, but also in carrier screening and reproductive couple screening in particular. Expanded carrier screening, prenatal testing is certainly ever on the rise, both targeted and more multi-gene or large gene panel prenatal testing. But even segregation testing, predictive testing, even areas where traditionally Sanger sequencing still looms large, we're now switching over to exome sequencing because it's just more efficient. But one of the main reasons we're doing that is, again, because we are very interested in something that goes beyond the immediate indication, and that is the question, what is the value of having comprehensive genomic data available for the rest of the life of that patient? How can we then use that data down the track to obtain additional information, whether that's in diagnosis, on prediction, polygenic risk scores we've heard about, pharmacogenomics, children that get their exome or genome sequenced eventually are likely to become parents themselves. Can we then use that data for reproductive couple screening? This is a concept of lifelong genomics, and that's something we're really now actively exploring. It's a question, how can we add on value to the data that we already have, and when do we best generate that data? I want to go through a few examples of where that matters and why that matters. One of them is, the obvious one we've kind of already started around. We are a pediatric institute by and large, but we also do adult work. Childhood is our key area of interest. And the diagnostics benefits of exome and genome sequencing in rare disease diagnosis, I think we have clearly demonstrated, and so have many others. And really, that derives from the fact that rare disease is really a misnomer. It's actually not all that rare. 1 in 17 Australians have some form of genetic rare disease. And over 30% of, or around 30% of babies that are dying in the first year of life have a rare genetic condition. Now, again, genomics in that space is now well established. I don't have to convince anybody of that. But one of our areas of interest was the space where the standard turnaround times, while they're generally now in the around 8-week mark, which is incredibly quick compared to years of diagnostic odyssey in the past. But there's children where that's just not fast enough, especially babies and children that end up in intensive care unit. Have a reasonably high, 5% of them have a genetic etiology. And in that space, decisions are made in the space of hours, right, and not weeks or months. So one of the projects we've done in this space using comprehensive genomic profiling is the acute care genomic study, which aimed to do ultra-rapid genomic sequencing, which started in 2018 and then over time evolved to roll out across the whole of the country. We ended up during that study until it closed early in 2022. This was available to every child that was in an ICU anywhere in Australia. And the key tenet here is that how do we make this faster? So we redesigned all our workflows and optimized everything for speed. We didn't worry about cost at that stage. And deployed initially whole exome and then in the second phase whole genome sequencing to push this as fast as we possibly can using a trio sequencing approach and dedicated teams or task forces of analysts, clinicians, bioinformaticians to chaperone every case through. The study is well published now, and the concept is well established and was very successful for us. Over the course of these 4 years, we have screened 450 critically ill babies, 160 by exome, and then 290 families by genome sequencing. Our average time to report was just under 3 days. The fastest one was in 47 hours. And 54% of the cases got a diagnosis with 180 discrete rare genetic diseases diagnosed. It also resulted in over 30 publications. We had, actually that's out of date, we've now got 10 new gene disease discoveries coming out of this cohort and won a couple of awards for that. But we also focused on education of healthcare professionals and health system implementation. Now, why does that matter? I'd like to share the story of little baby Levi, who was born after a normal pregnancy and developed seizures, really severe and difficult to control seizures on day 3. And we can see here a quote from his mother, how terrified she was seeing her baby seize and at times stop breathing. And Levi was one of the early children in our study, which we then managed to diagnose with KCNQ2 related epileptic encephalopathy, which was really critical because it resulted in a change in medication that put him on a drug that was otherwise rather low on the range of differential treatments. So he was seizure-free within 3 weeks, and where normally kids with that condition develop severe intellectual and physical disability due to the seizures, Levi has largely developed normal, is now walking, and we've got videos online of him sitting on a swing and running around a park, and he's starting to talk, I think, at this stage, which is unheard of, or almost unheard of in children with these conditions. And we have since identified 7 additional children with the same conditions, and as far as I know, all of them are having a much better developmental trajectory than normally would have been expected for this condition. So big impact for the children where we can find a treatment. But also, interestingly, very significant impact on the health system overall. The test is quite expensive. It costs $15,000. Australian dollars, but we have shown by deploying this through health economic analysis that it overall actually manages to save the Australian healthcare system $10.6 million after accounting for the high test cost per year, and that is largely due to the fact that a day in ICU costs $4,500, and the impact we have through very early diagnosis really reduces the time these children spend in intensive care. Now, another area where we're active in is reproductive health and reproductive screening, in particular recessive disease risk. And just as a reminder, pretty much everybody in this room is likely to carry some pathogenic recessive disease variant. that if you happen to find a partner that has a pathogenic variant in the same gene, you're at a 1 in 4 risk of having a child with a recessive disease. Actually 50% for X-linked conditions. Now this actually is also surprisingly common. About 2% of couples are at risk of having a child with a genetic condition, a recessive genetic condition, because they carry a pathogenic mutation in the same gene. And therefore, we've seen a really strong advent in the uptake of carrier screening. Most commonly, at least in Australia, that's 3-condition carrier screening for cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. But increasingly, we're screening for expanded panels, expanded carrier screening, which covers hundreds or even thousands of recessive diseases. And comprehensive genomic data really enables that reproductive risk screening. We have panels in place that screen for up to 1,200 genes, which evolved out of a project that I mentioned earlier, which was Mackenzie's mission, where we were part of multiple labs that screened over 10,000 couples in Australia. And really, we modeled our offering based on that. And I should say acute care and risk screening, these are all available now as routine tests. These didn't go away with the end of the study. We've translated them immediately into clinical practice, and they're all available now. And everything I cover today is or will soon be available as a clinical test. But we've also shown that there's a strong benefit to using a couple-based screening approach. So what does that mean? It means that we screen both prospective parents at the same time, rather than screening one partner first and then screening the second partner only when the first partner has something that comes up as high risk. The reason for that is the more genes you screen, the more likely you are to find something at high risk, and we can see that at this graph here. If you screen approximately 300 genes, 70% of individuals come up with a high-risk variant in one gene or another, whereas only under 2% of these then actually are at high couple risk, so are actually at risk of having a child with a recessive disease after you screen the second partner. If you screen over 1,000 genes, that goes to 90% of individual carriers. Now, the reason for couple screening is that it's then reduces the amount of high-risk reports to less than 2%, regardless of how many genes you screen for, and that really reduces not only the workload on the laboratory and the medical workforce, but also and critically reduces the stress on the parents and the prospective parents. And it's worthwhile noting that at this stage, at least, still most people that undergo carrier screening are already pregnant. And then having several weeks while waiting for your partner's result, if you're at high risk, is certainly a stressful period. The other thing that's interesting to note in this space is that the vast majority of couples do not have a known family history of genetic disease. And really, that is a very strong reason for using genetic carrier screening much more broadly across a population. And again, it's a key reason for, or a very good argument for reusing of existing genomic data and generating comprehensive data early, because it reduces both the time and the cost to returning then the couple screening result once people decide to consider having children. Now, the last area I want to talk about in this is a new project that's that we are about to launch and have got funded for last year, and that's the concept of genomic newborn screening. And this really evolved out of the Acute Care Genomics project, because at some stage we ask ourselves a question, while 3 days is really exciting and it's great to be able to do that quickly, the vast majority of the time is spent on generating the data in first place. It only takes us a few hours to analyze the data, but it takes us 48-ish hours or 40-ish hours to actually generate the data. So if we already had the data when the child gets into ICU, we would be able to return our results in a few hours rather than a few days. And more importantly, if we had the data available from birth, and that's a concept of newborn screening, we could have potentially prevented that child from getting into ICU in the first place. So newborn screening, for those that aren't as familiar with it, has been really around for over 50 years. It's traditionally called a heel prick test or a blood spot screen, where we've got Guthrie cards on the bottom there, where the blood spots are collected from newborn babies within a few days of birth. And initially they got screened for one condition, launched in the early 60s. Over time, additional conditions have been brought online, so currently there's over 20 conditions that are being screened. But as you can see from this graph, it can take many years, often decades, to bring a new condition online. And that's a problem both of scale and the fact that, scale because you're screening every baby at birth. The uptake rate is over 99% in Australia at least. And the fact that most of these tests are biochemical, so there's is in essence one method per test, which is very difficult to deploy at scale. So we are part of a number of a loose coalition across Australia where multiple labs explore different approaches to genomic newborn screening. And we have chosen to try to do whole genome sequencing on a subcohort of babies born in my state of Victoria. So launching, hopefully in a few weeks, we will be starting to recruit 1,000 Victorian newborns, and we will screen for over 500 treatable childhood onset severe conditions. And that's the power of whole genome sequencing. We're using whole genome. Is that we can add many, many conditions without incurring a methodological penalty. But the focus here is not so much on can we do whole genome sequencing on Guthrie cards. We know that already. It's how do we actually bring this into a healthcare system. The challenge is big. There's over 80,000 babies born in Victoria alone every year. So we're using a multidisciplinary approach with evaluating again the health economics, the implementation, the ethics, and the psychosocial impacts of the work we are doing. Because there's a number of key challenges in the space. Chief among them is retention of trust. Population-based screening only works if the majority of the population actually participates, and in particular newborn screening, which is arguably the most successful population-based screening program around, with, as I said, 99% uptake. We do not want to jeopardize that at all. There's massive implementation challenges. Genomics is still big data and expensive, and scalability and the question what to test for are key challenges. It's a very interesting space because although we can sequence all 22,000 genes, that doesn't mean that we should report on all of them at the same time. And one of the things that we probably don't necessarily need to do for a baby that's 2 days old is tell the parents that they may be at risk of developing breast cancer by the time they're 40. So we want to stay well clear of that. But what we do want to do is then, in the long term, over the future years, as these children grow up, then investigate the reuse of that data for exactly that purpose. Because in the future, that child may decide that they want to know their risk of breast cancer, in which case we can just go back to the data and ask the questions. And again, that's the concept of lifelong genomics. And for me, newborn screening is the logical entry point to that space, preferably with expanded carrier screening data available already from the parents. Now, there's additional requirements and opportunity for lifelong benefit generation. As I said, one thing that's severely missing right now is regular reanalysis of negative cases. Right? The vast majority of the data goes somewhere into the archive and is never looked at again, and there's massive opportunity hidden in there. There is definitely a need for indication-driven complementary data. We've already talked about cancer and somatic screening, methylome and epigenetic profiling, other multi-omic things, depending on what comes online. That will help interpret the data that we already have, because that is really the biggest challenge. We can sequence a whole genome, but we don't really know what it does. There's also strong opportunities for gene discovery and research collaboration, and two of them I just want to quickly go in. So again, one of our areas of research is automated reanalysis. We received another grant 2 years ago, which was based on the principle that most negative diagnostic data generated in Australia goes into archive and is never touched again until a clinician asks for that. And you've seen on the previous graph, our reanalysis rate is less than 5% of negative cases, which is desperately low, considering 20% of these cases will get solved. So we are now building a framework for automated reanalysis of that data, where we collect via multiple diagnostic laboratories in Australia. We collect the negative cases and we apply a automated reanalysis framework to it that is designed with a high level of specificity to find what is really the low-hanging fruit, right? A loss-of-function mutation in a new disease gene. And that is starting to really prove yield, and we're really going for something as simple as that. but will in the future then try to layer on machine learning and more sophisticated technologies. But we're not anywhere close to that yet. There's obvious answers in this data and getting those out in a way that doesn't overwhelm our diagnostic pathology laboratories and health system. That's the first focus of this grant. The other area is, as we've already heard about, methylation profiling. We have a project in play called the Ambrane Project, which really is designed to do CNS tumor methylation profiling in pediatric cohorts, which is now available through our laboratory to every child in Australia and New Zealand with a brain tumor. And eligible are individuals under 21 years of age, regardless of whether they have a primary or a relapsed tumor. It's a collaboration with multiple partners, critically funded by the RCD Foundation, Beanies for Brain Cancer, and the government, and working closely with the DKFZ in Germany. And we can do this on FFPE and frozen tissue, and I'm very happy to say that as of probably 3 months ago, we're now fully clinically accredited to actually provide this testing. So this is not a research project anymore, so it's pretty much the largest technology we've translated. What this does is it uses the EPIC arrays that we've already heard about to do epigenetic profiling on these tumor samples and stratify them into roughly 100 tumor classes using the epigenetic profile. And it's a study that has been started in 2017 at Monash University, and then after initial recruitment and validation, migrated to VCGS in 2021 together with the team, and as I said, in December we got NATA accreditation. The reason why we do this is so we can again have clinical impact with using that data. These are some of the demographics of the participants. You can see that the average age of our patients is around 5.5 years. And we can turn around this data in approximately a month, plus minus a few weeks. So as we scale this up, we will obviously get faster. The data is highly accurate. Sensitivity is 93%, and the concordance with our validation cohort was over 99%. I've got turnaround time in there twice. That's a bit embarrassing. But the clinical impact, so we see a change in clinical care in 22% of cases, with the majority of that being changes to the treatment approach. So again, it's a decent size impact for something that is really not, well, it's not that much of a used technology yet, and it's something, methylation profiling, that we would like to see a lot more in practice. Now, one of the areas we are exploring now is how and if we can move that technology from the arrays into the next generation sequencing space using the Twist methylation detection system. It's very early days for us, but the rationale for doing that is very similar to what we've already heard. There's just many more areas covered. It's a more comprehensive panel, and I hope that it in the future will allow us to reasonably easily add on additional indications beyond the tumor profiling, such as diabetes risk that we've already heard about. So once we've got the technology validated, adding additional indications is much easier than it is to validate from scratch. This is very preliminary data that, again, came off the machine early last week. And all I can tell you now is that we can see that the quality of the data is actually quite good compared to our control cohort. We do see, as we expect, a decent shift in the GC representation as brought about by the bisulfite conversion, but we don't incur a significant penalty in quality of sequencing data. The alignment rates are also very high, as we can see here, though what I do have to say is that the variability in coverage between the different samples we have is still quite strong. On the bottom here being the NTC and the control samples, they can be ignored. But we need to optimize this a little bit further to get it more balanced. I should say, though, this was a rather eclectic mix of blood samples, saliva samples, and FFPE tumor samples, so we need to potentially optimize by sample time. The good news is that all of these worked, and this is the first time we've ever touched this assay. yeah, just on a high level, we can see that it shows the expected results. So we've got here a sample from a female and a male individual, and I'll just show the exist loci on the X chromosome, and as expected, we can see the female shows evidence of X inactivation across the whole chromosome. This is just a sample loci. And interestingly enough, an area of interest for us is Fragile X, and the FMR1 locus is quite well covered by this as well. We see the expected signal. But as I said, very early day data. I'm happy that we got across it this far. We can see here that the conversion rate is not quite 100%, but we're, by initial estimates, certainly well in the 90% conversion. And we expect that with a little bit of extra optimization, this will be a very beneficial assay for us for two reasons. One is, as we said, it covers more data, so it's got potential for future expansion, but also being an NGS-based assay, it fits much better into already established workflows and automation. So we expect some efficiencies and cost benefits from that approach. Now with that, I'm going to leave you with my vision for the future. I think hopefully I've shown you that comprehensive genomic data has many advantages, whether that's primary diagnosis or reanalysis, and there's many areas where we can add additional value throughout the lifetime. Interestingly enough, I do expect that there's further improvements on the horizon from long-read sequencing technology. I'd love to see in the future an assay that can give me the whole genome plus the whole methylome in the same assay. Not sure if and when that's going to happen, but we're moving in a good direction. But none of that is a reason to not start now and use short-read data. The benefits that we can already extract from the current technology far outweigh what I think will be the future improvements. So there's no reason to wait any longer, in my opinion. In my ideal future, everybody will have their genome sequenced at birth, and we use that as a baseline, and so then continue to extract value at the right time for that individual, which for me is really the quintessence of precision medicine. And then we can also use other advantages. While there will be requirements for doing additional work in the future, when that patient develops cancer in the future, then Richard immediately has his germline control sequenced, right? So you can actually determine what the somatic mutations are using existing data. We need to really much expand the automated reanalysis and integrate new information much quicker. I have an anecdotal case where we analyzed and diagnosed a case 2 years after original report, and we found out that the paper that obtained the diagnosis was published 2 weeks after we issued the original report. I don't ever want to do something like that again. That kid could have been diagnosed a month after, and that's where we need automation. And yeah, we will enrich with additional data as needed. There's a cast of 100 contributing to these projects, so I'm highlighting just the key contributors here, especially Zonitsa, who is my partner in crime on all the research work and is also a clinical geneticist in the laboratory, so we work very closely together, both in the academic and in the clinical side. And Meg, who is my boss, and the genetic pathologist, who gives us a lot of leeway to experiment and try do this translational work, as well as the people from my team that are critical contributors. Thank you.